Welcome to this symposium. And thanks for Ji for giving us a good introduction so I don't have to repeat a lot of the things. Okay, Ji just touched on how marrow transplant or stem cell transplant works. This is a question that we always been asked, either from the parents, from the patients, and obviously from the media as well. What we know is that if you look at the blood cells under the microscope, they have quite a wide variety of cells. You have wax cells, white cell, platelets, and among the white blood cells, you have different kinds of cells like neutrophils, lymphocytes. They all make up the blood system. There are millions of cells in our circulation. But what is strange is that they all originate from one particular stem cell. And these cells just keep renewing and producing new cells in the body. That means that even if you wipe out your blood system or hematopoietic system, and you can get the stem cell back into your body, you are able to regenerate and replenish and rebuild your whole blood system and immune system again. And this is the main principles of how we are working with hematopoietic stem cell transplantation. As Ji has mentioned, we can now get stem cells not just from the bone marrow, where they usually live, but we can actually get stem cells from the bloodstream and also from the cord blood as well. The principles of doing a stem cell transplantation is like letting a house. Imagine if you have a tenant, you have let a house to a tenant, and you want to bring a new tenant in. The first thing you have to do is to get the first tenant out so that the new tenant can move in and occupy the home again. In real life, you can just use force or whatever the thing to kick the people out from the house, and then you can invite your new tenants in. But in transplantations, if we want to get the patient's bone marrow out, we have to use high-dose chemotherapy and radiotherapy, and this is one of the reasons why transplantation carries a risk. By using high-dose chemotherapy, we sort of wipe out the patient's whole blood system, immune system, and hopefully at the same time, we get all the cancers, leukemias away at the same time. And then afterwards, we put in new stem cells so that the stem cell can rebuild the blood system again. And with a new blood system, hopefully the underlying blood disease is cured, the leukemia disappear. And in terms of malignancy, the new cells actually carry out some of the killing of the leukemias. So that is the whole concept of stem cell transplantation, both in children and adults. Obviously, the current technology and success of stem cell transplantation won't happen over a short period of time. We have been in this field, or put it this way, transplantation has been with us for the last 50 years or so. And it was only until the 1960s before the first successful case of transplantation was reported. And not surprisingly, most of these success actually reported first in children. And in this particular case, there is this so-called bubble baby syndrome that was very rare, but it happened in every country and every nation. Children were born without an intact blood system or immune system, and they could die within months or within the first 1 or 2 years after birth from overwhelming infections. And in order to keep them away from infection, in the past, they were kept inside a bubble. But this is not the way, because even with very meticulous care, they still get infection from one way or another, and they cannot grow up normally. Until the advent of marrow transplant, these children have a very miserable life. But now with transplantation, we can actually offer cure for over 60 to 70% of those patients, especially if they came early without much infection. The chance of a successful transplant is actually very high. I started doing transplantation in 1990 when I was in London doing my training and work in the Great Ormond Street Hospital. This is one of the oldest pediatric hospitals in the world, and it's one of the leading center in Europe doing transplantation. This is the old part of the building. Actually, the new building is actually now behind, which is very modernized. The next question is, who can be the donor? Ji just mentioned to you about HLA typing. And if you look carefully, we have this HLA allele or genes that we inherited from one of the parents. For example, if we look at Becky in this example, she had one allele, the yellow one, from the father, and the green allele from the mother. Okay, so this is the genetic makeup of every one of us. Half of the gene is from the father, and half of the genes are from the mother. And it means that for one parent, they are only half matched with their children. Normally, in the past, we would tell the parents, I'm sorry, you cannot be the donor because you are not fully matched with your children. We have to look into other children. For example, if you look at the children from John and Mary, they can have 4 very different combinations based on the genetic makeup. Okay? But in this particular case, the last children, Sarah, is actually a fully matched donor to Peter. In general, you have only 25% chance being fully matched with your sibling, either a brother or sister. And these fully matched siblings still represent the best possible donor for transplantation compared with other types of donor. So if you can get a matched sibling in the family, we always choose that as a donor because this is the highest success possibility and the lowest cost and complications. But what happens if we don't have such luck to have a matched donor? In that case, we'll have to look for alternative donors. Either, as G mentioned, unrelated donors all over the world, which we have now computerized and linked together so that we can search. We can search for donors from America, from Europe, or even from Brazil to see whether you have a matched donor or not. That solves a lot of problems for most of the patients, but as we are working in Asian, as we just learned, we still have some deficiencies because patients from minorities, especially from the Middle East, from the South Asian countries, still we cannot get donor from the unrelated donor registries. In that case, we have to turn back to the parents, where we have to use special maneuvers to make them into suitable donor for their children. Thalassemia and sickle cell anemia is a very common disease worldwide, especially in this part of the world. If you look into the whole population of Singapore, Malaysia, India, or even the Middle East, up to 10% of the population are carrier of thalassemia of one form or another. And worldwide, thalassemia and sickle cell anemia is actually the most common genetic disorders that can affect a lot of different peoples in the world. Children with thalassemia are born normal, but when they start to grow into 5 to 6 months of age, the anemia start to appear. And from that on, they have to rely on lifelong blood transfusions in order to survive and to grow. And this is a very torturing disease in terms of blood transfusion and the complications of blood transfusion. It is this reason why, when I started the transplant program in Hong Kong, we focused specifically on thalassemia. Queen Mary Hospital is actually the oldest hospital in Hong Kong and is affiliated with the University of Hong Kong, where we started the transplant program there. This is the little girl with thalassemia back in 1993. This is the mother, and this is her fully matched donor. That day, we have actually admitted the donor, and he actually donated blood for himself. You can see the unit of blood he donated by himself, where we preparing for the marrow harvest. And this girl is actually back in the hospital for blood transfusion, and she is wearing this bag, which carries a syringe pump. Because in order to keep the thalassemia stable, we have to tackle one of the major complications of blood transfusion, which is iron overload. With blood transfusion, this elemental iron accumulates in your body. And most of the thalassemia patients now, they don't die from anemia. They actually die from the iron toxicity because of heart failure, diabetes, and sometimes liver failure. And she had to give this iron chelation by an injection which she had to puncture into her tummy every day. By the time she went to sleep, the infusion goes on until the next morning, and she woke up and then pulled out the needle before she changed for her school. So we can imagine, in the daytime she went to school, nighttime she came home, start the needle injection again. This is a very, very torturing disease in most parts of Asia, where thalassemia is very prevalent. But she was very lucky because her brother can be a donor, and she had a very successful transplant. So in 2008, the family, the donor, the patient, and the mother are spending their life as any normal family. And she even went into college, graduated from the university, and is now working as a social worker. Last year, she just gave birth to her first child. So this is all the success stories that we can look into children with serious illnesses and transplantation. Sickle cell anemia is another disease that is equally torturing, if not worse. They don't necessarily go on to regular blood transfusion, but the sickle cell anemia crisis can be very crippling. Like this child, Hamid, even though he doesn't need blood transfusion as often as other people, but he has been crippled and stay at home because of all the painful crises, occlusive crisis. And he was quite lucky again because he has also got a fully matched donor, and he chooses to come to Singapore to have transplant. And after this, he told me he had a very renewed life because he can now go back to school, he can swim as normal as other children without any fear of going into painful and crisis again. You probably have these leaflets in your pamphlets. I hope the marketing people have included this as well, so that you can understand how, as a mother who had gone through with the child for the last 15 years, how life has changed after transplantation. And in pediatric in particularly, patients don't sometimes come with one disease. Sometimes they come with two diseases. Like in this particular child, who come to us with both sickle cell anemia and SLE, systemic lupus erythematosus. And this is the worst thing in the world when you have SLE and sickle cell disease at the same time. Okay? It's like being tortured every day, even worse than the meat that you have seen. So again, the good thing is this one, we kill two birds with one stone because the transplant is a treatment for both sickle cell anemia and lupus. And we have actually done a few transplants for patients with a combination of disease like aplastic anemia and Fanconi and leukemia. We have done Fanconi's anemia and sickle cell anemia. They are very funny combination of disease in children, which you don't see in adults because they have no chance to survive into adulthood. Leukemia is still one of the most common indications for transplant, even in children. Nowadays, in pediatrics, the successful treatment of leukemia is actually very high with just chemotherapy alone. But still, there are 10-20% of children whose leukemia is not well controlled or relapse after treatment. And this is a time we are having problem and we have to go for a transplantation. Patients sometimes came to private, not just because of the expertise we can offer, but also the kinds of support we can offer in a private hospital. This child is having treatment in hospital for leukemia and transplantation, and I mean, they can actually quite stay very comfortable even though they are receiving treatment in a hospital. Okay, and the mother is just sitting there leisurely watching TV, not actually the child. And she also gave us her account and story of how she had experience in Singapore with the transplantation, which she really could not find anywhere else. So I hope you can have this pamphlet in your pocket as well. And what about other diseases? In pediatrics, we have a lot of diseases that we can treat with transplantation. And without transplantation, they all die during very young childhood. We have conditions like adrenoleukodystrophy, which is a kind of metabolic disease. Metabolic disease are conditions in which the food substance you eat, when they absorb inside the body cannot assimilate or break down effectively. So these food substances start to accumulate in your body. Instead of being nutritious, they become toxins, and you die from what you have eaten, which is a very torturing and painful procedure. And because of this nature, they are often multi-systematic. It means that they can affect a lot of organs, your brain, your eyes, your bones, your liver, and sometimes your blood system as well. Osteopetrosis is a very funny disease in which your bone keep on growing and calcifying, but you cannot get rid of the calcium from the bone. So what happens is, when you have osteopetrosis, your bones continue to calcify, and it starts to squeeze your own support, your own normal organs. For example, your eyes are sitting comfortably in your orbit. You don't feel it. But imagine if your bones are growing and the orbit starts to shrink down and press onto your eyes just pop out, and within a few months, you are blind from the disease. And this happened to this little baby from the Middle East. When he came to us, he was 13 months old. And imagine his body weight is only 5 kilos. He cannot grow because of the disease. 5 kilograms is something like a 3 months old. So instead of 13 months old, he came in a size of 3 months old. He cannot move, but have to lie in the bed all day. And worse, he was blind, even though he was 13 years old. So he cannot see us. What he can see is just bright lights. You wave your hand in front of him, he blink his eye, but he do not know what you are doing. And in this case, we couldn't find a donor. None of the siblings are matched, and the parents are only half matched. We searched the unrelated donor registry, no donor in the west of the world because they come from a minority race. In this case, we turned to the father, who willingly offered himself as a donor for the child. What happened is, after the transplant, the bones start to improve. You can see in the old days, the bones are solid mass, but now you can see inside the bones, you can see some space inside the bones as well. And this is a sign that the disease is now recovering. And surprisingly, the child starts to see afterwards, which we don't expect at that time because normally blindness is irreversible. But this child was quite lucky. Maybe we did it just in time. He recovered about 70% of vision and is now running around, going back to school. So this is Mount Elizabeth Hospital where I'm doing most of the transplant now. So I hope as the team is building up, we have a much better support to the family, to the patients, and we can offer more innovative treatment to patients in need. Just in summary, we are now doing transplants from all over the world, not just locally. At the same time, we can offer transplant to children with a variety of diseases, including blood diseases, leukemia and cancer, and metabolic disorders. And we can transplant with different types of donors, either related sibling, unrelated donor, cord blood, and even parents who are just half matched with their children. So I hope you can go home with informative pamphlets and material, and you have a better understanding of what we are doing to our patients in need as well. This is the whole team from PCC, which I'm sure you have met them last night, if not, maybe today or later today. Thank you for your attention.